I'm Janet Steffen, RN, and I serve as the staff support for the care coordinators of SERPA-ACO. Care coordinators play a very vital role in the success of the ACO's Patient-Centered Medical Home, or PCMH. Each clinic has at least one care coordinator, and depending on the size of the clinics may have 1.5 or 2 full-time care coordinators. As the clinic is set up and designed differently, so is the role of the care coordinator. However, our goal is to achieve the same results throughout the ACO. Care coordinators may be an RN, LPN, or a CMA or certified medical assistant. Care coordinators need to be compassionate, empathetic, have good listening skills, and triage skills. An important goal of the ACO is to help keep the cost of health care down. As a PCMH, we try to include the patient in their care so that we can stay ahead of any issues that may cause them to be hospitalized. Once the patient has been hospitalized, then we work very hard to keep the patient from being readmitted to the hospital. We do this by following the Transition of Care Code requirements that are billable by Medicare and some of the private insurers. The Transition Care Code billing requires that a patient that has been discharged from the hospital be called within 48 hours or seen face-to-face within the same time frame. The care coordinators are responsible to make these phone calls. They want to know how the patient is doing since they have been discharged, who they have for a support system, if they have a follow-up appointment, and if not, help them schedule an appointment. Medication errors are one of the main reasons for a hospital readmission within 30 days. We want to make sure that they are taking the correct medications that they were discharged with. The same event also occurs with patients who have been in the hospital, went to a skilled nursing facility, and are now back in their own home or assisted living facility. During the time in the hospital, we often find several changes in medication dosages or medications being started. Sometimes, because of the list of approved drugs from a pharmacy, they may be taking a different drug that is in the same family, and it is even more confusing. However, if we are going to keep the patient from going back to the hospital, this review and reconciliation of the various med lists is critical. We also make sure that the physicians or mid-level providers have all of the helpful available information about the patient before their visit to the office. This often means contacting the hospital or nursing home, getting the information into the EHR, or copying that information for review. We do the same type of follow-ups for patients seen in the emergency room and make sure they get followed up in the office so their needs can be met. If they frequently go to the ER, then we work to find them better ways to get their care. When time allows, some care coordinators are asked by the physicians to help with some of the social needs of our patients, such as transportation, finding good caregivers, and keeping families informed. The care coordinators meet about every 8 weeks. We discuss workflow issues, quality measures, best practices, and have guest speakers. This is a time for the care coordinators to do a lot of networking. Our biggest challenges are to keep our patients healthy, get them into the clinic to be seen, make sure they get their preventative care, and encourage them to do everything they can to stay healthy.